Section 7, the newborn exam. Understand the important elements of a prenatal history as they relate to the health of the unborn child, including the importance of maternal age. So, advanced maternal age makes you more likely to have certain genetic conditions like Down syndrome, certain chromosomal anomalies. So on prenatal history, maternal age, we want to know mother's STD screening results, HIV, RPR, gonorrhea, chlamydia, syphilis, hepatitis status, particularly hepatitis B status, group B strep status. We want to know if mother had a prenatal ultrasound and what those results were. We want to know mother's blood type. Can't remember if I said that already. Mother's blood type. Any pertinent maternal history. For instance, if mother had lupus, we might be worried about maternal heart block. If mother had gestational diabetes, we might be worried about hypoglycemia in the baby. So we want to know a lot about the maternal history. Any medicines that the mom took, a maternal history of HSV, or medications that they took for HSV, maternal history of depression or anxiety, or medications that they took for that. All of those things would be really important. Remember, there's two persons in one body, so anything that goes into one affects both. So we want to make sure that we're aware of anything that mother ingested during pregnancy. Recognize factors in the perinatal and newborn history that may put a neonate at risk for medical problems. Certainly maternal smoking, which I should have mentioned on the last learning objective, maternal hypertension, any trauma to the mother, or social issues, anything that happens right around the time of delivery, so in that perinatal period. So mom developing chickenpox in the perinatal period, abruption, bleeding, meconium, anything that's outside the realm of normal during labor and delivery, decelerations of the heart rate, prolapse cord, extra bleeding. We want to know those kinds of things, when we get the history on the baby. Describe the transition from intrauterine to extrauterine environment, including temperature regulation, cardiovascular, respiratory, glucose, and initiative of feeding. So let's start with temperature regulation. So they don't have to do any temperature regulation when they're inside of mom. Preterm babies don't have a lot of extra fat stores. Remember, they put on those extra fat stores in the last several weeks of gestation. So anything before 35 weeks or so may have trouble regulating their body temperature and may have to go in the incubator, which I affectionately refer to as the box. So anything smaller than 35 weeks may require an incubator. Want to make sure we're keeping a hat on, socks on, keeping them swaddled so that they stay nice and warm. We don't want them overheated. That increases the risk of SIDS, but we want them just a comfortable warm temperature. All right, cardiovascular respiratory adjustment. Remember that really complicated lecture I gave on all those things that change in the heart and the lungs? Yeah, that's what we're talking about here. So remember, your foramen ovale is going to close. The ductus arteriosus is going to close. That's going to happen gradually over those first couple of days of life, first week or so of life. Your ligamentum venosum is going to form because that shunt is going to close. Your pulmonary vascular resistance is going to make a huge drop during that first breath and then continue to drop gradually over the rest of that first month of life. And if any of that goes wacky, then funny stuff may happen that we need to be paying attention to. Glucose regulation, the baby's been at the buffet or at the picnic basket for the last 9 months, getting all that sugar through the placenta. If mom was a diabetic, baby may have been getting a whole bunch of sugar for the placenta and may have a really big pancreas, because remember, insulin doesn't cross the placenta, but glucose does. So once we clamp that placenta, we may need to monitor baby's glucose carefully. It kind of depends if they're too big, so LGA, or too small, SGA, small or large for gestational age. That's what the GA is. If they're an infant of a diabetic mother, if they're preterm, then we're going to monitor that glucose and make sure that it stays stable, and if it doesn't, that we fix it. Initiation of feeding. Babies are usually really awake for the first couple hours after birth, and then they get really sleepy for the next 24 or so hours. So making sure that we are feeding adequately during that time frame, whether it's breast or bottle feeding, that we're supporting the mother and the baby during that time frame. Oftentimes we like them right after they're born, during that golden hour or golden 2 hours for the C-section babies, to go right to breast and begin to nurse when they're in that really awake phase, begin bonding and nursing with the mother. Identify key concepts used in the clinical evaluation of gestational age and stability at birth. So we can estimate gestational age using a Ballard score. A Ballard score is a series of maneuvers and exam findings that helps us estimate gestational age if we don't know it. When I was in residency, we did Ballard scores on every single baby so that we got comfortable with how to do it in case we didn't have estimated dates on a baby. Mother didn't know she was pregnant, came in, dropped a baby. How old is the baby? It uses a series of maneuvers that assess tone in various body parts. For instance, the scarf sign. How far across the body can you pull the arm? Does it go all the way across? Does it stop here? It also looks at how much hair is on the baby's body, how mature the earlobes and the bottoms of the feet are, how mature is the skin, the genitalia, to make an estimate of gestational age. I do not think you need to know every detail of the Ballard score. Just know that it's out there and you can use it to assess gestational age. And using gestational age can help you determine clinical problems that the child may have. And weight also. So APGAR score, remember, tells you acutely how the baby is doing. It does not predict long-term outcomes. Appearance, pulse, grimace, activity, respiration. We did that in that neonatal sim, so I know all of you remember that. Tells you acutely, not long-term. That's the important part about that score of 0 to 2 for each category. Weight and gestational age to categorize potential clinical problems. 500 grams and 24-ish weeks are the cutoff for viability. Anything less than that, it's really not considered viable. I say 24-ish weeks because sometimes we're not too certain what those dates are. The more premature they are, the more problems they're likely to have. Learning disabilities, attention deficit disorder, seizure disorder, cerebral palsy, chronic lung disease, respiratory issues, certainly feeding problems, anemia, retinopathy of prematurity is one that we really haven't talked about anywhere else, and then bleeds in the head in premature babies as well. Those IBH or interventricular hemorrhages, make sure that you review the ROP and IBH, because that's not something I feel like we've learned much about in other places. All right, familiar with newborn exam and underlying pathology of certain findings. Scalp swelling. Two main things that cause scalp swelling are going to be cephalahematomas and caput seductum. That's a funny word to say. Cephalahematomas are going to obey your suture lines. Those are blood collections, hematomas, right? That are going to occur along the skull, outside, right? Not inside. Parents always ask that question. And they're going to obey the suture line. So often they're going to feel like a very discrete bubble. They're not going to be kind of smushy and diffuse. It's a discrete bubble of blood that occurs occasionally in traumatic, sometimes even non-traumatic births. You'll get a little cephalhematoma, and that resolves over the first months of life, so they may have a little calcification there forever. They just have a lumpy head, but everybody has a lumpy head, so that's not really abnormal. The caput is just diffuse scalp swelling from the process of being born. That often feels squishy, and it does not obey the suture lines. All right, what's next? Absence of red reflex is going to make you think about congenital cataract. Remember, that can be caused by your torch infection, so you want to make sure you review those and know those. There are other causes of absent red reflex, like galactosemia, that you'll see later in life. Galactosemia, red reflex, man, that's always a board question, so make sure that you cement that one in your brain. Heart murmurs. You can hear a heart murmur on a newborn exam. Remember, just because you hear a murmur doesn't mean there's something abnormal structurally in the heart. It's just like hearing water flow through the pipes in an old house. Just because you hear the water flowing through the pipes doesn't mean there's a structural problem or a leak in the pipes. Just means you can hear it and there's a flow. Very similar in the heart. No, there's, physiologically, there's so many things that have to happen and change in the heart that are happening in that first couple of days when you're examining the newborn. But you want to be aware and make sure that you're not letting go of a critical congenital heart disease. So you may want to get 4 extremity blood pressures and pre and post ductal saturations to make sure that you're screening properly. Skin findings, skin tags, extra digits, rashes, HSV, your normal newborn rashes like erythema toxicum, pustular melanosis, neonatal acne, milia. You want to make sure you're looking for all of those fun things. Ortolani and Bartlow, remember your screenings for hip dysplasia. Ortolani out, Bartlow back. You want to make sure you're screening for those. We want to find hip dysplasia early on. We want to treat it early on so that we don't have that big ugly surgery later in life. We'd much rather put them in the cute little harness early. List the complications and differential diagnosis for the following common problems that occur in the newborn. The first one is jaundice. So, ABO incompatibility. Oh no, mom is O. We need to do a blood type on baby. If baby is anything other than O, we're worried about ABO incompatibility, right? Oh no, mom is O. Also, if mom is Rh negative, baby needs a blood type because if baby is Rh positive, we want to give mom RhoGAM or WinRho, whatever you call it at your institution. So ABO incompatibility, sepsis, prematurity are the things that can make babies jaundice. Complications of jaundice, kernicterus, which is the bilirubin staining in the brain, happens at levels higher than 24. We're very aggressive at treating jaundice. We treat it like 5 at 24 hours, 10 at 48 hours, 15 at 72 hours. It's really not quite that level, but that's a good kind of quick cutoff in your brain, 5, 10, 15. 5, 24, 10, 48, 15 at 72. If it's anything higher than that, you need to go put it in BiliTool. I know you know what BiliTool is, and if you don't, you need to call me. BiliTool.org, put the age, put in the number. It tells you exactly what to do. If they're a preterm infant, less than 35 or so weeks, can't use BiliTool. Look up the graph on Google. You'll find the preterm infant graph. We treat jaundice with feeding and phototherapy. They need to poop and they need to be under the lights. That's how we're going to get rid of the jaundice. Respiratory distress in a newborn, sepsis, pneumonia, RDS, TTN. So sepsis and pneumonia, you understand that. TTN is transient tachypnea of the newborn, more likely to happen in C-section, termish babies that didn't go through the squeeze of the vaginal delivery. Your chest x-ray may show fluid in the fissures. RDS, respiratory distress syndrome, is more likely to be in your preemies, going to have that ground glass appearance on the chest x-ray, and it tends to linger quite a bit longer than the TTN does. TTN usually resolves pretty quickly. RDS hangs around. Poor feeding, low blood sugar, jaundice or hyperbili, respiratory distress, hypoglycemia, sepsis, all of those can cause poor feeding. Complications are that they can get all of those things, hypoglycemia, jaundice. We really need to get the baby eating. Differential diagnosis for LGA babies, gestational diabetes. SGA babies, substance abuse, placental insufficiency, infection, chromosomal anomaly. Complications really depend on what the cause is. Sepsis, well, that's infection, so there's your differential diagnosis. Group B strep, vaginal flora, GI flora, anything that lives in the GU area can cause sepsis in an infant. Remember that we do those Group B strep swabs at 36 weeks. And how do we treat it? Pause. How do we treat it? Think about it. IV ampicillin, 2 doses, first dose at least 4 hours prior to delivery. That is the only acceptable treatment for Group B strep unless you've done a culture with sensitivity. I don't care what they're allergic to. I don't care what you gave them. If you didn't do a culture and sensitivity, your patient is not adequately treated for Group B strep. If you did a culture and sensitivity and you see their GBS is sensitive to whatever you want to treat them with, and you show me that piece of paper, then they can be adequately treated. Otherwise, they're not adequately treated. Okay, thanks. All you future OBGYNs out there. All right. Very good. Treatment for Group B strep during the perinatal period does not prevent late onset GBS sepsis, but it can prevent early onset GBS sepsis. Complications, of course, anything that can go with meningitis, hearing loss, sepsis is bad, renal failure, bad stuff. Hypoglycemia differential diagnosis, sepsia, infant of a diabetic mother, or sepsis, infant of a diabetic mother, hypoglycemia complication, seizure. When you get that sugar up, remember a normal blood sugar is around about 50 in a newborn. We need to supplement. If it's less than that, usually by feeding. If it's less than 20, they're at risk for seizure. Drug withdrawal or exposure, we use the PASS score, which are the NAS, Neonatal Abstinence Syndrome Scoring System, to evaluate for drug withdrawal. So you don't always know that mama's been on drugs. If there is suspicion, then mom gets a drug screen and baby gets a urine and meconium drug screen. Your urine will tell you acutely, your meconium will tell you more long-term what the mother has been on. But drug withdrawal can be a very real problem. We treat that withdrawal acutely with the appropriate drug that they're withdrawing from, and then long-term, typically with methadone, if it was a similar medication they're withdrawing from. Prematurity, infection can certainly lead to premature delivery, fetal anomaly, uterine anomaly. A lot of the premature births are inductions for maternal factors like pregnancy-induced hypertension, preeclampsia, eclampsia, or placental anomalies, previa, bleeding, and the like. All right, demonstrate knowledge of the indication for newborn screening for torch infection. So if you've got a little bitty baby that's sick, they have an abnormal rash, a big liver, a big spleen, blueberry muffin spots, boards like blueberry muffin spots, so know what those are, know what causes them. You're going to want to screen for torch infections, toxoplasmosis, other rubella, CMV, HSV, HIV, or your H's. And there's more than that, but those are the ones that are listed on the torch. Identify what medications are given routinely. Vitamin K, vitamin K doesn't cross the placenta. So we give that IM injection right after they're born to prevent hemorrhagic disease of the newborn, which can be acutely life-threatening, and once it starts, it's a booger to stop. Hepatitis B vaccine, we usually give that in the first 24 hours of life to prevent maternal transmission of hepatitis B, and then eye prophylaxis to help prevent one of the leading causes of blindness worldwide, which is STD exposure to the eye. Typically that's with erythromycin eye ointment. Identify treatment options for hyperbiliary. It's phototherapy and feeding. And be aware of the AAP's practice guideline on treatment of hyperbiliary in healthy term newborn. We use BiliTool to help us with that. Exchange transfusion, if it gets anywhere above 20, close to 24, is typically what happens. Clinical manifestations of congenital hypothyroidism. So, to me, what's important about congenital hypothyroidism is what to do if you get a positive newborn screening for it. And what to do is to immediately get a thyroid level, right? We want to prevent the clinical manifestations. I mean, newborn screening is universal. Everybody's getting a newborn screening for thyroid disease. If it's positive, you need to know what to do, and that's to immediately get a TSH and a free T4 level. And then if that is abnormal, is to immediately call the local pediatric endocrinologist and immediately start supplementation or do whatever they tell you. Don't repeat another newborn screening and wait 2 more weeks to get that back and then decide whether or not you need treatment, because then you're going to see the clinical manifestations, and we don't want to see that, right? Big tongue, big fontanelles, developmental delay, growth problems. We don't want to see any of that stuff. So when you get an abnormal newborn screening, you want to immediately take action and draw levels, and you want to immediately act upon that. You want to do that with anything you get on newborn screening. Newborn screening is going to tell you exactly what to do on the bottom of it. And if you don't know what to do, just call your state newborn screening people and they will tell you what to do. Don't sit and wait on abnormal newborn screening results. That's Dr. England's 2 cents on abnormal newborn screening results. Be able to provide anticipatory guidance on breastfeeding, normal sleep patterns, car seats, prevention of SIDS, and the role of circumcisions. I think we've covered all of those things except for circumcisions. Circumcision is still covered, still considered a cosmetic elective procedure. It is supposedly, there is some evidence out there, not supposedly, there is some evidence out there that it prevents STD transmission, but it is still considered a cosmetic elective procedure. Just briefly, I'll cover the others in case you skipped to this video and didn't watch the others. Breastfeeding, breast is best, but not at the sacrifice of maternal mental health, or if they're on certain medications, also shouldn't breastfeed if they're HIV positive. Sleep patterns, no REM sleep until 6 months, so you can't sleep train before that. Normal sleep patterns are very much cultural and very much child dependent. Appropriate car seat, less than 2 rear facing. Once they outgrow the height and weight requirements on that sticker on the side of the seat, they can be turned forward facing. Still want to be in a 5-point harness until we, again, outgrow the height and weight requirements on the side of the sticker. Then they can go to a booster. I prefer high back boosters because they have that shoulder strap adjustment. We want to be in a high back booster until 4'9", 80 pounds for a standard passenger car. Then we can come out of that, but we still want to be in the back seat. Prevention of SIDS on our back in our crib with the ceiling fan on, nothing else in the crib. All right, that's it for this section.